Welcome to the Cass Health Podcast, the show where we hope to connect our community with healthcare information that's relatable, understandable, and useful to your life, and where you get to know better the neighbors providing your care here. I'm your host, Ann McCurdy, and I'm joined today by Dr. Chad McCance as we talk about Colorectal Cancer Awareness Month. Before we get started, two quick disclaimers. First, the comments in this podcast do not necessarily reflect the views of Cass Health. Second, the information in this podcast is not intended to be construed as personal medical advice. Always consult your primary care provider with your questions and concerns regarding your health. Dr. McCance, welcome to the podcast. Thank you so much for taking some time and talking with us today.
Thank you for inviting me.
Part of the goal of our podcast is to let the community know better the people who are providing their care here. So we'd like to ask some questions, starting with, where are you from?
I was born in Colorado, but I spent most of my life in Nebraska, so I consider myself to be from Nebraska.
And a Husker fan?
Yeah, I was raised pretty much as a Husker fan most of my life. Not much of a sports fan, to be honest with you, but I still consider myself a Husker.
I'm a Husker, too. I'm from Omaha, so I cheer for everybody, though, honestly. If you're cooking dinner to impress, what are you cooking?
I do a lot of different things. Mostly I just kind of throw stuff together in my kitchen. I like to do a lot of cooking, though, and so I tend to make chicken most of the time, some different kind of chicken. Dinner, I like to bake it or grill it, different things, but probably chicken of some kind or other.
And if we got you $50 to spend locally, where are you going and what would you get?
I could spend $50 in McDonald's, but now probably the most likely place would be one of the parts stores. I use all three of them, but the car parts stores, I like to work on cars as my main hobby, and so I spend most of my money at those places.
And what will we never catch you doing?
Never catch me doing.
Yeah, we liked this question with Dr. Reinhardt because he immediately was like, karaoke. I'll never do karaoke.
I wouldn't mind doing that.
Oh,
now, probably,
good to know.
I don't do alcohol, so probably be out drinking would probably be the one thing that you'll never catch me doing. So
that's good. That's probably I probably don't want to see my general surgeon out.
Yeah, probably not a good thing. So.
Probably not a good thing. What's better, the book or the movie?
In general, I prefer the book.
Favorite book or favorite type of book?
I love reading. I do most of my stuff audiobooks nowadays, just because I have a hard time sitting still. So I do, but I'm constantly listening to some form of an audiobook almost all the time. I go through a couple hundred a year, but probably science fiction, fantasy mostly. But I do a lot of that.
Sure. Is that something that you do when you're like working on your cars too? Is that?
Yeah.
Oh, neat.
When I'm working on my cars, I don't listen to much music. So when I'm driving in my truck to and from work, or when I'm working out, or when I'm mowing the lawn, pretty much constantly I'm listening to an audiobook when I'm sitting in the cafeteria eating my lunch. So.
Yeah, it's a great way I find it's a great way just to kind of like decompress and like let myself think about something else for a while. So, wow, a couple hundred a year.
Well, I maybe not quite that many, but I've got over 500 audiobooks in my Audible library that I've listened to. So since it came out a few years ago, so
that's awesome. You just answered this. If you're driving alone in the car, you're probably not jamming out. You're probably listening to an audiobook, huh?
Yeah, unless I'm in my Bronco, and when I listen to in the Bronco, I can't hear the words very well, so I usually put music on so that I can hear when my phone rings. So
what are you listening to in the Bronco?
I have a playlist that different music that I like. I don't have any one type of music I like, but mostly I listen to probably mostly country or 80s rock.
Sure.
Which kind of to me goes together. So.
So, but current country or 80s country, like
little
classic
both.
Country? Little both. Okay. High school or childhood nickname?
Never really had one. When I was in medical school, I had a nickname with my fraternity, which was Thor, because I was in the military at the time, but never really had any nicknames when I was growing up.
So Thor didn't stick.
Except for my cousins called me Chadwick for some reason. I don't know why.
Chadwick, huh?
Yeah, I never really liked that, but so.
Well, we won't tell people to call you that one. How about the next or your dream travel destination?
Well, I've been to Hawaii a few times, and that's usually my dream destination. Although lately the travel has been so difficult getting there, the air flights. Probably, and then my next destination is going to be Idaho when we go pick up my daughter for college. So I'm really looking forward to that, though.
Idaho's beautiful,
It
too.
is. I love the drive over there.
Yeah. We always like to ask our guests why they chose the career that they're in. So for you, can you tell us, why did you choose medicine? What was it about medicine that interested you? And then along with that, how did you end up choosing general surgery?
When I was in, second grade, I guess, that was kind of a funny thing. My second grade teacher was giving me a hard time about my poor handwriting, and she said I ought to be a doctor. And so, me being the smart aleck I was, I said, okay, I will be. Second grade, and so
And
here I
that
am.
was it?
Yeah, that was part of it. And then when I was in high school, they asked us to do an essay, and I decided that I wanted to do. I was best at science. I always liked the sciences, so I decided I wanted to be doing something in the sciences, and I decided I wanted to do something where I could help people. So I went into medicine.
And so as you're going through medical school, and where did you go to medical school?
University of Nebraska.
University of Nebraska. So at some point during medical school and then during your residency, I mean, you have to make this choice that general surgery is right. So how did you come to that decision?
I really liked endocrinology in college, and I thought I wanted to do endocrinology. And then I got into medical school and found out that endocrinology was an awful lot of sitting around and writing prescriptions and things. And I'm more of an active person. I like doing things, and I really enjoyed my surgical services. And I really liked orthopedics, and I thought I wanted to do that for a while. But then the attending doctors and the residents that I worked with in orthopedics were just not very nice people. So I actually ended up, I liked the people that I worked with in general surgery better, so that's why I chose that.
Yeah. I think one thing that I hear from a lot of our doctors who choose to work in a rural setting is that you get a variety of things here, and that you see different things every day, and that's part of what they love about their job. Would that be true for you too with general surgery?
That's a large part of it, but even more so is I'm just not a big city person. I don't like the city. I go there to get something done, but I want to come home. I'm not a big city person. Never have been.
Yeah. Do you want to talk at all about your military background or any other background, education or training?
My military background was more of an aside. I did that as when I was in college. I needed a job during the summer, and I didn't have one lined up. And one of my friends wanted to go have me take him to take the ASVAB test to get into the Army, and I went with him, and they talked me into taking the test at the time, and then I did really well on the test, and so they said they offered me a job then, and one really recruited me hard to come into the military. So I thought, fine, I'll do it. I didn't have a job for that summer, so I joined the Army Reserves, and I enjoyed it a lot. But I went in when I was in college, so I went in as a medic, and I didn't do a lot with that until when I got out of medical school, or then I was commissioned as a captain and was in the medical corps as a general surgeon there, and I spent some time doing that. But mostly I did the same job as I do here. I didn't really do anything, and I was only in the Army Reserve, so I only did it part-time. So my military career was more of something I did in addition to my general career. So.
And residency, where was your residency at?
In Des Moines.
In Des Moines.
Primarily at the Des Moines VA. I did 1 year at Mercy Hospital, and then 4 months at Phoenix General Hospital doing trauma. So
I was trying to remember the other day about when you came to Cass Health, and I was thinking it was about 2010? 2008. Okay, 2008. So you've been here, over a decade now, and still love it?
Yeah, oh yeah, I love Atlantic.
So March is Colorectal Cancer Awareness Month. This is a topic we've talked about before, but it's so important, I think, to keep front of mind for a lot of people because those screenings are so important. So we'll first start with, what is colorectal cancer?
Colorectal cancer is, well, it's cancer of the colon. It's generally a mesocolon type of mesodermal type of cancer from the lining of the colon, and it develops into primarily an adeno type of carcinoma, which is the most typical type of cancer that you see in the colon. We do occasionally see some other things like lymphomas and some smooth muscle tumors, but those are pretty rare. Primarily adenocarcinoma is what we see most. Squamous cell carcinoma of the anus.
And who's at risk for these types of cancers?
Everybody. Mostly it has to do with age. In general, over the past many years, they've gradually set the timing for when we need to start screening. It used to be at age 50 because most of the people who get colorectal cancer are over the age of 50. We have recently been seeing more and more of them in younger people, so they've recently changed the recommendations to begin screening at age 45. But in general, it's because that's where the most common number of people are seeing the development of colorectal cancer in people over the age of 50.
So what are some things that might put me at more risk?
There are several things that will put a person at increased risk of colorectal cancer. The most important one is family history. If you have a family history, particularly in a first-degree relative that has colorectal cancer, you're at significant risk. There are several particular types of polyposis syndromes that really put you at significant increased risk, such as Lynch syndrome or familial polyposis. If your family has either of those, you're at significantly higher risk. Other things that can increase your risk are, for some reason, African American race puts you at a slightly increased risk. Other things that'll put you at risk are a low fiber and high fat diet, being overweight, having a sedentary lifestyle, and probably one of the other most important things is a previous history of adenomatous colon polyps or previous colon cancer.
And along with all of those things that put me at risk, are there warning signs or, for those early things, like are there things that I could realize are red flags?
That's one of the worst parts about colon cancer. There really aren't a lot of warning signs. It's not something that you can see or touch or feel, so people will tend to put them off. The only true warning factor or warning signs that we'll see is occasionally blood in the stools, because colon cancer tends to be what we call friable. That means if you rub it, it bleeds. But not everything that can bleed will bleed all the time. So it's not something that shows up all the time. So it needs to be tested, and it's not something that you'll generally see in the stool all the time. So it's one thing that we need to test with the chemical test. If you do see bright red rectal bleeding, that's of course a warning sign. Of course, there are a lot of things that cause bright red rectal bleeding that aren't cancer. So that's one of the things you need to have a conversation with your doctor if you do see blood in the stool. But the main signs that you might see with colorectal cancer are blood in the stool, either microscopic or visible, and occasionally some abdominal discomfort or change in your bowel habits. Persons who have increasing constipation or constipation associated with alternating with diarrhea.
So what types of screenings are available? And, you talked about this a little bit, but when do I need to be screened? Is this like an annual thing?
Yeah, there are several types of ways to be screened for colorectal cancer. There's the chemical test, the stool test, the IFOB test, the fecal occult blood test that we have used for many years to just detect blood in the stool. The newer one called Cologuard is also out now, and that's a little more specific. It detects blood, but it also can pick up certain DNA markers. So it's a little better test than the regular IFOB test that we used to have. Still a significant number of false positives and negatives, so it doesn't completely eliminate the need for colonoscopy, which is the gold standard for screening for colon cancer. Then there's also the imaging tests, the baryonenomas and the CT colography that we can do that also screen for colorectal cancer. The gold standard is colonoscopy. When do we start screening? Again, at age 45 is the recommended time to start screening, and then based on what we find during those initial screenings, we'll determine how often you need screening afterwards. We recommend colonoscopy every 10 years for people who don't have any significant risk factors, including the family history, the previous colon polyps, and those sorts of things.
To clarify, too, you said first-degree relatives, so we're talking mom, dad, siblings.
Correct.
Okay. If I don't have any symptoms, do I really need to get screened?
Like I said before, the most common symptom for colorectal cancer, nothing at all. No symptoms at all. So absolutely, you still need to be screened.
And I know nobody loves getting a colonoscopy.
Yeah, and that's strange to me. That's something that one of the conversations I have with my patients usually is that this should be something that people are excited for. In my opinion, it's one of the best screening tests that there is out there. No other screening test that we have can actually prevent any kind of cancer. You never see somebody whose mammogram has prevented them from getting breast cancer. You never see a pap smear that will prevent you from getting cervical cancer. You won't see a chest x-ray preventing you from getting lung cancer. It can detect it early, but it will not remove that tissue and cause you to not get that cancer. Whereas colonoscopies, we can detect a colon polyp in the early stage, and we can prevent you from getting cancer in the first place.
Because during the colonoscopy, you're able to just remove that polyp right
Correct.
then. So
And we do.
And so it's not a separate procedure. It's you're inspecting and you're removing any of those things that you're seeing.
That's correct.
So is a colonoscopy really that bad? I mean, it seems so awful and embarrassing. And how do you talk to your patients?
I've had it done twice, and I work with the people that I've had every day, and I didn't find it embarrassing in the least. You know, we do like to have a pre-op visit that I speak with patients, and I go through the whole procedure in my office before we schedule them for the procedure. So we go through a lot of the details of how to do it and what to expect at the time of the procedure itself in my office before that's ever scheduled.
That's a good idea. So they get to know you. They know the
Right.
procedure. They know what's going to happen.
We also go through the instructions on how to take the bowel prep and everything.
Sure. I would assume that helps kind of ease some of the anxiety.
I think it does. And I also talk to them a lot about the false positive and negatives regarding the Cologuard test because, like I said, when people hear that they have a positive Cologuard test, the first thing they think is, oh my God, I've got cancer. And that's not always the case. In fact, most of the time it's not the case. But it is something that, of course, everybody worries about.
Absolutely.
We all know what's going to happen in there, and you have the bowel prep done the day before, and most people complain about that the most. And it's really not that big a deal. Our new bowel preps are so much better than they used to be. They're not the high volume preps that they used to be, and you take them, you have diarrhea, which obviously isn't a lot of fun, but it's just part of the preparation. And as long as you accept that you're going to have diarrhea and get cleaned out, that's really not that big of a deal. It's not that bad. And then you come in, they give you your IV, they take you back to the scope room, and you're completely covered the entire time until they give you your medications, and you go to sleep. And then you wake up, you're in the recovery room, you're totally covered, and nobody is seeing you while you're awake. And while you're asleep, everybody is very professional. It's done. It's a clinical procedure. Nobody is concerned with what you look like or anything like that. We're there to take care of the patients. And honestly, I don't really understand the whole concern about the embarrassment factor because you're completely. We protect your modesty during the procedure.
Absolutely. Yeah, I think about those blanket warmers, and you're wrapped up in a nice warm blanket, and you do. We use some anesthesia here, so you don't remember the colonoscopy.
Right. We're very fortunate in our hospital. And many of the smaller endoscopy labs that you'll see in the big city where people will go over for their endoscopy, they'll use nurse anesthesia. And I don't mean to denigrate nurse anesthesia at all. They do a great job. But here, we have our nurse anesthetists provide anesthesia. Nurse anesthesia can only provide a certain amount of, or certain types of medications, whereas our nurse anesthetists are able to provide the whole gamut of anesthesia. And they're able to use actual anesthetic medication, not just the sedation medicines. And so I used to say when we do these procedures, you probably won't remember anything about the procedures. But I can pretty much guarantee almost nobody will remember anything about what goes on during this procedure. Our anesthesia providers are very good.
Yeah, they are. They're excellent. You've got a great team back there.
Absolutely.
So you talked a little bit about cases in young adults are kind of increasing. Are you seeing that here locally?
Yes, I've seen several people in their 20s and 30s that have developed colon cancer here in our hospital. So it's not something that's just old age, but still, far and away, most patients are over age 45 before they get it. We get a few in the younger ages, but not very many.
But not very many. I assume in those cases they are seeing some of those warning signs, or they've talked to their doctor, or they know they have that family history.
In general, they're usually identified because they have some of the warning signs.
Warning signs,
yeah,
sure.
That's not something that we screen for in young people, so there has to be some reason why we look.
Right. So you talked a little bit about some of the factors that I can't control. What more can I do to protect myself?
Well, like I said, as far as the risk factors, the most important things are avoiding the lifestyle things that we can affect. Our diet. Low fiber, high fat diet is known to promote colon cancer. So a high fiber, low fat diet is helpful. Vitamin C supplementation has been shown to be helpful.
Oh, okay.
Avoiding a sedentary lifestyle, being active, keeping your weight under control, avoiding alcohol and tobacco. Those are the main things that we know of that can be affected. Very important.
So it sounds like colon cancer is one of the more preventable types of cancers because you've got those lifestyle things you can do, and then with good screening.
Yeah, you'd think so, wouldn't you?
Yeah.
But unfortunately, it's the number 2 cause of death from cancer in the United States.
Wow.
In men, it's behind lung cancer and lung cancer and prostate cancer. In women, it's behind lung cancer and breast cancer. But when you mix both sexes, it's the number 2 cause of death from cancer, and it is something that we can prevent.
Do you think that that's partly because people don't get screened?
That's a large part of it, that we don't get screened. Certainly, there are patients that will develop colon cancer despite screening, and because nothing in this world is perfect. Even colonoscopy isn't a 100% preventative against colon cancer. A small polyp can be hidden and we can miss it. Obviously, we do our best not to, but it does happen. But the most of the time when we see colon cancers develop, it's in the first time they've had a colonoscopy. So it's because they haven't received a screening beforehand.
Can you talk a little bit about, because there are those different tests like Cologuard versus colonoscopy, they're not a replacement for colonoscopies.
No, they aren't. They're kind of a pre-screening. People who, and honestly, I'm a big fan of the Cologuard nowadays because we've had a lot of people who've refused to get colonoscopies for years and years, and then they do the Cologuard and it comes back positive, and they come in and get their colonoscopy then, because it does wake them up and help them to realize how important it is, and that they are at risk. And then we can go in and remove the polyps that we find. And I've had several people that have had that come in and found multiple polyps that we removed and had a good potential of preventing them from getting colon cancer. But no, they are not a replacement. They're a supplement.
So they can be complementary, but that, like you said, the colonoscopy is still the gold standard.
Correct.
So starting at age 45, about every 10 years for most folks, if there's no family history or other risks or anything, that's not so bad.
It's not. Like I said, I'm 56. I've had it done twice.
Yeah. So probably off a day of work, I would assume.
Right.
Typical.
You have to take the day off of work the day of the procedure. And depending upon your work, some people will need to take the day before off for the prep, especially if you work nights. That's going to be difficult. So.
Sure. And then with the anesthesia, somebody to drive you to and from, I assume.
That's correct.
Okay. What else should we know about coming in for a colonoscopy? Anything we didn't cover?
I can't think of anything other than that it's something that I'm a huge proponent of. I believe strongly in doing this for our patients. It's something that I think has a chance to really help a person prevent them from becoming another statistic in the colon cancer war. So we do a great job here.
Excellent. I vaguely remember, and you can tell me if I'm crazy, but smoked meats and charred meats?
Yeah, that's true. I forgot to mention that.
Isn't that something that, like, because I know this because I come from a family that we love smoked meats.
Yeah.
And so when you mentioned that, I thought, oh, no.
It's mostly the charred meats that have been known to cause certain types of cancer, not just colon cancer.
Sure.
The smoked meats and some of those things that have a high salt content are actually more risky for gastric cancer, and pickled meats and things like that. But any kind of charring of meat does have some carcinogens within it, so it does add a slight increased risk. That doesn't mean that barbecue is bad. It just means if you like your food burnt, and it's probably not so good.
So maybe don't eat burnt food every day.
Right. It's better to have it cooked appropriately, but not charred.
Yeah. I know that you practice what you preach, and I know you're looking forward to exercising with your daughter today. How about fiber? Is that something that, you talk a lot to patients about?
Yeah, every day. Fiber is supplementation. We don't get enough fiber in our diets here in America, and it's something that it's not just for preventing colon cancer. It also helps to reduce the risk for diverticular disease and hemorrhoids problems. It helps to keep your bowels regular. It's very important to supplement your diet with some form of fiber. A high fiber diet is useful, but even when you try to take a high fiber diet, it's still usually not enough fiber in your diet to reach the recommended dosage that we need. So
do you recommend like supplements like cookies or biscuits, or like do you use like a Metamucil, like something that you stir in?
Yeah, I'm a big fan of Benefiber myself, but some of the Metamucil cookies aren't too bad. One of my common things that I say to patients is, no medicine in the world sitting in your medicine cabinet does you any good at all. If you're not going to take it.
So whatever you like then.
Exactly.
If you
That's
like
the most
it, and
important.
you'll do it regularly, right?
That's the most important thing, is getting it in your body. But Benefiber, the reason I like it is it has no flavor. You can mix it with water and you don't even taste it. So it's really very easy to take and not something that is going to cause you to put it off and not do it.
Easy habit to develop then. Yeah. Thank you so much for your time today. We really appreciate you coming in, so thank you.
You are welcome.
So March is Colorectal Cancer Awareness Month, and we know one thing that plays into our colon health is eating enough fiber. So today we have Beth Olsen, our registered dietitian, with us talking about how to get more fiber into our diets. So welcome, Beth.
Hey, thanks for having me.
So let's talk about fiber, right?
Yeah.
So tell us a little bit about the role fiber plays.
Yep, absolutely. So fiber is found in our plant foods. And there's different types of fiber. If you've heard people talk about soluble fiber and insoluble fiber, so that soluble fiber is kind of like the Cheerio box. They're like, we're going to lower your cholesterol, right? So things like oats. And then the insoluble fiber is more things that like add more bulk to your stool. They can help prevent constipation, make it easier to go. Regardless, like you don't need to think about it on that deep of a level, but both of those are going to play a really important role in helping you feel fuller, longer. They can also help decrease our risk for things like heart disease and cancer, and sometimes they can help us even manage our weight as well.
Managing our weight because we're feeling
fuller, right, exactly. So you're going to take longer to digest those foods, and so if we're feeling more satiety longer, we're less likely to keep snacking or going back, and so just overall can be important in maintaining a healthy weight.
Let's start with the first meal of the day, breakfast. What are some ways we could incorporate more fiber into our breakfast?
Right now, a lot of people are still doing oatmeals and stuff because it's not quite warm enough out yet, right? So something like a nice hearty oatmeal. Some people will put wheat germ or maybe some nuts on top of that. If you are doing like breads or something like that, I prefer people choose more of the whole wheat bread or the whole grain breads. The nuttier, the better. The more fiber you're going to get. So, or you can find maybe some people like a granola that they put on top of a yogurt, but things like that, oats, whole wheat breads, of course, fruit, right? Adding, berries to oatmeal or making
raspberries
a smoothie.
In your oatmeal. That's my jam.
That's your jam.
Yeah.
Okay.
And I just keep the frozen raspberries.
Yeah,
so
absolutely.
You just take a scoop of those, throw them in, they cool down your oatmeal.
I was going to say it cools down your, you don't, there you go. That's brilliant. I love that.
It's delicious too.
That's great.
So, and then lunch and dinner, how do we, or even snacks during the day. So having, like you've mentioned, mentioned before, keeping some fruit with you during the day, maybe.
Yep, absolutely. So fruit, anytime you can add more fruits and vegetables, right? And eat the skin on it, right? Some people peel the skin off their apples. No, that's the fiber. That's what I want you eating. And anytime you can grab a piece of fruit rather than fruit juice, I tell people to do that because you're not getting the fiber and the extra nutrition out of apple juice that you would from eating an apple or from an orange rather than drinking orange juice. So I'd much rather people eat the whole fruit rather than, peeling it or drinking the juice version of it. So smoothies, for example, you're still getting the whole fruit, right? So you might be drinking it, but you put a whole fruit in there. So I think that anytime you can add more fruits and vegetables is a great thing. You mentioned snacks, nuts are a great or seeds are a great snack that you can have in the afternoon, and they're great protein too. So it's going to help keep you fuller longer. It's got good fiber, and we know that can certainly help with feeling fuller longer too.
The types of fiber that I like might stir into a drink, or I think there's like wafers or cookies or crackers and those sorts of things. A good source of fiber, is that something you would look at or something you would recommend for people?
Yeah, and you could talk to your doctor, so like a Metamucil type drink or something like that. So some people do like those. It helps them stay more regular. But they can also help lower our cholesterol too. So I know that some people, especially who have a hard time keeping those cholesterol numbers down, will do something like a Metamucil just to help bind some of that extra cholesterol before it's absorbed. So you certainly can do that. But I think the important thing with, that is you're drinking a big glass of water with it too, right? And so that's one thing that's really important when it comes to fiber. Yes, it's important to eat more, but are you also drinking enough liquids too? Because it's really important to get, try and get at least 8 cups a day. And don't just throw all of your fiber in at once. If you've been eating like the white refined products, don't be like, tomorrow I'm going to get all my fiber in, because it's probably not going to go well.
So it's something you build up gradually.
Add up to it. Yep, yeah, absolutely. So, and drink the extra fluids along with it. Brown rice is another one, or whole wheat pasta are some ways that you can get a little more fiber in and not much of a taste or texture difference. So some things out there, there's, I'm not bashing any brands or anything, but like Fiber One products, for example, that's just one that comes to mind. Sometimes they put fibers in there that aren't easily digestible, and so they can cause a little GI distress. So I always like to, for somebody that's like, I'm going to increase my fiber and get all these bars, and that's how I'm going to do it. Just a word of caution that sometimes those can cause a lot of GI distress and upset. So yes, you're getting some more fiber in, but just notice if you're really feeling kind of grumbly and crampy, it might be that you're just really sensitive to some of the fibers that they're putting in those products to help you meet your fiber goals. So you can't go wrong with getting that just from your natural fruits and vegetables and whole grain products.
And all the same advice for kids, right? Fiber in kids, also, once you're a parent, it seems like you begin talking about poop every day, from the time they're in diapers, and it just goes on. But all the same advice, right?
Yeah,
fruits and veggies,
absolutely.
Keep your fluids going.
Yep, yeah, absolutely. And maybe it's just because my kids have a dietitian as a mom, but they're very in tune with that themselves, and they'll be like, my 3-year-old's like, sure, Mom, I'm constipated and I need to eat more fiber. What 3-year-old says that, right? But it's like, I'm so glad you've acknowledged that. You're right, you do. And then we talk about what foods can help with that when you do have a tummy ache because you haven't eaten enough fiber.
Well, okay, now here's the other question then. Well, I give my kids pear juice or like prune juice. That was the recommendation at the time. What does the dietitian do?
So I wouldn't say that my kids have a ton of issues, but yeah, I think that, generally I think pediatricians probably say if it's like a one-time off thing, something like that can help get it moving. But, I don't think that's an everyday recommendation, right? You don't want your kid loading up on juice every day. Yeah. But that juice is so concentrated sweet that it pulls water in from your body, and it's going to help the kid go to the bathroom. And so that's why a lot of people will do something like that as a quick fix. But, overall, I think it's slowly incorporating more fiber into your kid's diet or your own diet so you don't have to deal with this every day. How can we just get you in a pattern of just being more regular yourself?
Just by incorporating regular fruits and vegetables and drinking water.
Absolutely.
Well, awesome. Thank you so much for being with us today, Beth. We always love to see you here.
Yep. Happy to be here.